Okay, hey guys. So tonight we're doing chapter 13, environmental emergencies. We're probably going to move through this one pretty quick. It's not super hard, so we'll get started here. As always, try to get my computer to work. There we go. So we're going to talk a little bit about submersion incidences and temperature-related illnesses. Most of you have had classes like this, so it's um, not going to be a big deal. Figure out why in the world I've got blue dots on there. Um, So when a person's exposed to excess heat, the body's mechanisms for regulating that get messed up. They get overwhelmed. They don't know what to do. And we get things like heat cramps, heat exhaustion, and heat stroke. In that order, we'll break each one of them down. Exposure to the cold environments, um, hypothermia or frostbite, we'll break that down. And then unintentional exposure to water can lead to submersion injuries and drowning. So, as always, you guys are starting to see that maybe I was right. We're going to do our assessment every single time. We start with scene size up, primary survey, history taking, secondary assessment, reassessment. We want to review that dispatch information. And we're going to get into this a little bit, but I'm going to stop for a second. Um, on these type of calls, this dispatch information and your common sense is key. It's huge here. Make sure that we are wearing the correct clothing. Make sure that we are um, not putting ourselves in a dangerous situation. So it's always our safety, our partner safety, our patient's safety. And we're going to talk a little bit about that, but I can't stress that right there enough. Assess the scene for safety issues. This can be getting out of the truck and walking up an icy driveway. If the incident is a submersion issue, is there rapid water moving? Um, is it lightning? Is it hailing? Is there an active tornado? Those are the things we need to consider on these types of calls. As you perform a primary assessment, try to form an impression of the patient's condition. You know, we've talked about that general impression. As soon as we see them, what do we see? What do we think? Um, Determine the patient's level of responsiveness, AVSPU. Introduce yourself if they're alert, um, or verbal, or um, even if they're not, we should still introduce ourselves. Check that patient's ABCs. So airway, is it open? Breathing, is it adequate? And what rate is it? And circulation, so C, do we have a pulse? Is the pulse, what's the rate and the quality? And also, as always, with circulation, what's our skin temperature? What's our skin color? What's our cap refill? That will tell us a lot. With that being said, when we do hypothermia, it's a little bit different animal, and we're going to talk about that here in a minute, but we're going to have that cold or cool skin if they're in hypothermia. We might have really weak or thready pulses, or you can't find a pulse, but we'll talk about that. Acknowledge patient's chief complaint or life threat. Can they tell you what's wrong, or do you have to figure it out? Usually, it's best to collect a medical history or of medical patient. Hmm, of a medical patient before you perform a secondary assessment. If they're able to tell you, great. Is someone on the scene a friend or a family member? Can they tell you? Use sample format. So signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events leading up to. Your secondary assessment. Focus on areas related to current illnesses. Um, what we've been learning in class, yes, we focus on the problem, but we also can be checking all of the body systems. We can listen to lungs, we can listen to heart, we can watch chest movement. We can touch that skin and check their skin. We can make sure their eyes are tracking and dilating and reactive and equal to light. We can talk to them. Are they giving appropriate answers? Are they slurring their words? Um, we can check all the body systems, most of them just by talking to them or laying our hands on them. We don't have to do a strip from head to toe trauma naked type deal. We then wanted to get those vital signs, blood pressure, blood sugar, pulse quality and rate, respiratory quality and rate, temperature on these might be really important. Um, I'm sure I'm missing something. Oh, our AVPU. Every time we do a vital, we do an AVPU. And then monitor throughout this ongoing assessment. When we're done assessing, we reassess. Um, that is right in my way. See if I can move this. There we go. So heat cramps, um, painful involuntary spasms of muscles. I think most people have had a heat cramp at sometimes when that muscle just tightens up and it just painful. It's pain. Usually it's in the calves. It often occurs after exercise or especially in hot weather. Never fails. Mine hit me in the middle of the night. I'll wake up and my leg's just killing me in one of my calves. Occurs most often in the leg and calf muscles. I guess I need to read before I talk. When the abdominal cramp occurs, it may appear that the patient is having an acute abdominal problem. My computer's not liking me. Um, Move the patient. So treatments, sorry, is let's move that patient to a cool place. Have the patient lie down in a comfortable position. Give the patient water to drink. I don't recommend just chugging bottle after bottle, but let's get some fluids in them. Can also use things with electrolytes like Gatorade, Powerades. My favorite go-to is Pedialyte. Um, if cramps do not disappear or the patient is young, old, or has a chronic medical condition, let's arrange for the patient transport. Let's get them, we can get IV started. We can start running fluids and get them to the hospital. Heat exhaustion. This is that second one. So we're getting worse as we go. Pay attention to these numbers also, because I'm betting that they're on a test question or two. Occurs when a person is exposed to temperatures greater than 80 degrees Fahrenheit, 27 Celsius, usually in combination with high humidity. It can also occur as a result of vigorous exercise at low temperatures. So it doesn't have to be super hot for this stuff to happen. Most people, summer hits and they're like, "Oh man, it's bad. It's 110 out." Well, this stuff can happen at like this says at 80, where we got really high humidity. Um, so we got to watch those. So signs and symptoms of heat exhaustion are profuse sweating. We're just pouring our fluids out, lightheadedness, dizziness, nausea, weak pulse, and blood pressure. If you're around someone um, and you see these things, let's treat them then. If we get called out to this, we can ask these questions. You can tell the clothing will be wet from sweating. Hey, have you been dizzy? Do you feel lightheaded? I like to ask if they have blurry vision. Do you feel sick? Uh, so these are all the things we really need to look for. Uh, Predisposing factors may make some people more susceptible. So if you're very young or over 65, this can affect you more drastically. Pre-existing medical conditions, certain medications, high air temperature, high humidity. So treatment for these patients is you move that patient to a cooler place and treat him or her for shock. Same thing. We've talked about what shock is a little bit. We'll go into that in the shock chapter, but remember when you go into shock, your body's pulling everything to the core to try to protect your vital organs. So we still need to lay them down, give them high flow oxygen, and just put a sheet over them. We still need to try to maintain that body heat on those extremities that are losing the body heat. Unless a patient is unconscious, nauseated, or vomiting, give them fluids by mouth. Once again, you don't want them just chugging bottles and getting waterlogged, but they can sit there and drink water while you treat them, while you talk to them. Monitor the ABCs. We've already went over ABCs. So arrange for transport to a medical facility. On these, hopefully you've got an advanced or a paramedic and we can start a line and get fluids running. So here's the big one. This is the scary one. The heat stroke, it occurs when the body is subject to more heat than it can actually tolerate. And the normal mechanisms in your body to get rid of excess heat, such as sweating, are overwhelmed. This is why they say that you're not sweating or the patient wasn't sweating due to, and it's extremely high temperatures. Um, their body doesn't know how to react at this point. You have more or less short-circuited that ability in your body. Um, so the patient's body temperature rises until it reaches a level which the brain damage occurs. Um, so when our body short circuits and we don't know how to sweat, we don't know how to get that excess heat out of our body, um, our temperature starts climbing up and up and up, and then that's when we're going to get that ultramental status. We're going to get the unconsciousness, and it can get like deadly. Signs and symptoms. So we're going to get that flushed, dry skin that feels hot to the touch. Altered mental status, verbal to unresponsive. Um, so verbal means, I get their attention by talking, but do they make sense? That's a big one right there. Or they're just going to be flat unresponsive. Um, Initial temperatures as high as 104, or I'm sorry, internal temperature will be as high as 104, and Celsius at 40. Treatment is maintain that patient's ABCs, especially if they're going unconscious on you, and remove the patient from a hot environment. Um, Remove the patient's clothes down to their underwear. This is a really good thing. You can put a sheet over them and soak that sheet. You can pour water directly on them too if you want. I've been on a couple calls where I didn't have water available. So, you know what? Normal saline. I tore a bag, I cut the top off, and poured the normal saline on them. These are some of the things you can do. Be aggressive in cooling these patients. Squirt them with a water hose. It says shower. I don't know a situation where I would drag someone into the shower. Um, Ice packs, pack them in the groins, the underarms, behind the head, on the neck. Um, we're going to do everything we can to help this patient cool off because their body's not able to do it. If the patient's conscious and not nauseated, administer small amounts of cool water. Right there is a huge part. Um, Give me just a minute. Try to. I'm trying to use my mouse and it disappeared on me. There we go. I want that. I want that. Okay. So right there, we want to pay attention to that small amount. So we're going to take sips, um, chug water, arrange for rapid transport to an appropriate medical facility. So there's another one of them trick words, appropriate medical facility. Once one of these people have an issue like a heat stroke, it will always um, make it hard for them to be in the heat. So here's a quick table. It breaks down the difference between heat exhaustion and heat stroke. It can be really hard because, as we know, every patient presents a little bit different. So heat exhaustion, you got normal body temperature. Heat stroke, you got high body temperature. Heat exhaustion, we're still sweating. Remember, we are perfusing. Our shirt's soaked in sweat. It's just pouring off of us. We're a heat stroke. We're not sweating anymore. Um, we're going to be cool and clammy on a heat exhaustion. Heat stroke, we are hot. Our skin probably red. You can touch these people and know, oh my gosh, they're burning up. And then you got dizziness, nausea. And then with heat stroke, you're going to be semi-conscious or getting real close to being unconscious. You're not going to be making sense, confusion, saying the wrong word for simple sentences, that kind of stuff. And then frostbite. So this is on the other side of the spectrum. Now we're getting into the cold. Um, this is when body parts get exposed to the cold. And the most susceptible body parts is your face, ears, fingers, toes. So why is that? Think about you go out. I'm going to say when you was a little kid, if anybody was like me, it snowed. I couldn't wait to get outside. Most of the time, I had 4 or 5 layers on my upper body and lower body, but my hands, I had a pair of gloves or light gloves. Might have a stocking cap on. Um, Most of the time, I didn't have a full face mask. Our ears, and then our feet get wet. Unless you have really, really good boots, and even then, they get cold after a while. So these are the things that we have less protected, or the less clothing on for protection, and so they are more susceptible to get that injury. This chart depends on the wind's velocity. I thought, hang on, okay, I think it says it somewhere. Maybe not. Um, so you can have like a 30-degree day or 35-degree day, but if you have a, trying to see if I can find 30 degrees here, 30 degrees with a 15-mile-an-hour wind is a temperature of 19. Wind plays a huge factor in how cold it actually is. And where we live or where I live, it's nothing to have a 25-mile-an-hour wind with a 20-degree day. That drops it down to 3 degrees. So frostbite can take place within 30 minutes. And this chart, if you look at it for a minute, you can tell by color coding, um, 30 minutes, 10 minutes, 5 minutes. So wind chill plays a huge factor. Most susceptible people are those weakened by old age. We've got thinner skin. Our pump's not pumping quite as well as it used to, probably. Um, Medical conditions, exhaustion, hunger, all this plays a role in frostbite. Superficial frostbite, or frost nip, is another name for that. It affects affected body parts become numb and they turn bright red. Uh, in color. Once again, as a little kid, you'd stay out until your hands were literally on fire and bright red. You were getting pretty close to frostbite at that point. Eventually, area loses color and becomes pale. It will get really light colored. Um, there may be a loss of feeling and sensation. Uh, see, warm area must be done quickly and carefully. Do not warm area by rubbing it. So we're going to time out for a minute. This is super important. Um, And I never knew this. Everybody rubs their hands together, or you go in the house and mom sits there and she'd rub your hands between her hands trying to warm you up. This is a big no-no. Um, what's happening is we can actually freeze the fluid that's in our tissues, cause ice crystals. Ice crystals can then, if we're rubbing, like cut and damage tissue from inside. Um, so we don't want to do that. Once again, frostnip, treat patient for shock. Let's cover them up. We got to warm them up. So we are going to cover them up, high flow oxygen, get them laid down. Then we go on to deep frostbite. Patient skin will be white and waxy, and that's exactly what it is. It's a waxy feeling. Um, just it doesn't feel like human skin at all. Skin may be firm or frozen, so it's going to be hard. It could have swelling or blisters. Um, if the if skin has thawed, it might appear flushed, or appear purple and white, or maybe mottled or cyanotic. To treat this, follow your scene size up, primary assessment, secondary assessment sequences, remove any jewelry from the patient that's covering that, and cover that extremity with a dry cloth or dressing. Don't break blisters, don't rub the area again, apply heat, and allow that patient. Yeah, that's not worded right. Do not allow that patient to walk on those extremities. If they have their feet, their legs, don't let them use those extremities. Provide prompt transport to a medical facility. Hypothermia. So we're still in the cold. It occurs when a person's body temperature falls to a subnormal range below 95 degrees or 35 Celsius. The person's body is unable to produce enough energy to keep internal temperatures at a satisfactory level. Um, People that are most susceptible to this, those with inadequate or wet clothing. So we didn't dress properly, or we went out and played in that slushy snow and got really wet. Um, Individuals who are weakened by illness, intoxicated patients. So we've got thin blood, we're not thinking. We might pass out in the snow, we might pass out in just in the cold weather. Um, and patients who have abused drugs are at an especially high risk for developing hypothermia. Um, so signs and symptoms: feeling cold, there's shivering, decreased level of consciousness, sleepiness, lack of coordination, mental confusion, slowed reaction. As that body temp goes below 90, patient will lose consciousness, weak, and very slow pulse. That's why I said you might not be able to feel a pulse. They could have one. You might not be able to tell they have one. Once again, just a breakdown of things that you can see, signs and symptoms at different temperatures, the cardiorespiratory response at different temperatures, and then the level of consciousness. And this is at core temperature. So this is your body's core temperature. So the treatment: move that patient to a warm location, remove those wet clothes, get wet clothes off of them, place warm blankets over and under the patient. Um, and the reason for that's in another chapter, but if we take a super cold patient or a super hot patient and we lay them on something that is just as cold or colder or just as hot or hotter, um, the temperature will go. If I lay down on cold concrete floor right now, my back is going to absorb that cold, right? Um, so we want to be careful where we place these patients because we might be defeating the purpose. If middle of the summer and I go down for a heat problem and you lay me on hot concrete or asphalt, one, yes, you're going to burn me, but two, I'm going to conduct that temperature. It's gonna, we're gonna, temperature's going to flow into me. So I, there's a word for it. For the life of me, I can't think of it right now. When we get to that chapter, we will go like into depth on how that works. Um, Radiate, convection. There's like 4 or 5 of them we'll talk about. If a patient is conscious, give them warm fluids to drink if available. Stay with them. We've got to watch them ABCs, make sure they stay conscious with us. If you do not have access to a building, move patient to a heated vehicle. So in our line of work, hopefully we're on an ambulance. Um, Something I was taught in school is you don't set that temperature in that box to where you're comfortable. You set it to where that patient's comfortable. Multiple times, dead of winter, I'm working on a patient in the back and I'm pouring sweat because I've got it cranked up there, 75, 80 degrees to keeping someone warm. Um, so we always make it comfortable for the patient, not ourselves. So treatment, if transport's delayed, you may need to use your own body to heat that patient up. Handle patient gently. This is another example of we don't want them walking. We don't want to roll them a whole bunch. Um, because if we have those frozen crystals within our tissues, we don't want to be slicing up tissue. Um, Hypothermic patients must be examined by a physician. This is where it gets a little bit kind of confusing. Not really, but cardiac arrest and hypothermia is hard because if that patient's body temperature is less than 83, heart may stop and you will need to give CPR. Always start CPR and use an AED on hypothermia patient, even if you believe they have been dead for several hours. They're not considered dead till they're warm and dead. So hypothermia has actually saved lives before because it slows everything down so much. We can't find a pulse. They're cold to the touch. They're unresponsive. Um, might barely be breathing. If they are, we cannot assume someone in hypothermia is dead because they have all the signs of it. We have got to work that patient or do CPR on that patient until they are warmed up to normal temperature. So we got to get them out of that cold. We've got to be doing CPR, giving air, doing what we're trained to do until they are at a normal temperature. And even then, we're going to call that medical director, or hopefully we are arriving at a ER and we can go from there. Um, but they're not dead until they're warm and dead. So grounding and submersion, I'm not going to spend a lot of time on this because this is not my field of expertise. So each year, more than 3,500 people die from unintentional drowning. It's the second, I would remember this. It's the second leading cause of injury and death among children 1 to 14 years old. Drowning is defined as the process of experiencing respiratory impoundment from suffocation or immersion in liquids. Let's go ahead and do this right here. So if you guys go back and watch this or whatever, or go through these slides, you can have this. Um, so drowning is, oh, got a little wild there. Um, there we go. Prevention. Once again, different chapter. This right here, this second leading cause in children's death, 1 to 14, can be prevented by parents staying with kids, having fences up around swimming pools. And I think it gets into it here in a minute, but it can be a mud puddle. It can be 6 inches deep. It can be a mop bucket sitting in the kitchen that a little toddler looked into and fell in. It can be a bathtub. So there are ways to prevent these from happening. And I've preached to you guys, part of EMS is education. That's why I kind of off rail sometimes. Um, these things are preventable. We just need to educate people every chance we get. Submersion injuries result from being beneath surfaces of water or other liquids. Likely location of drowning: streams, lakes, swimming pools, hot tubs, wading pools, public fountains, storm drains, or ponds. Um, hazards for infants: like I said, bathtubs, toilets, mop buckets. Um, they're preventable. It's sad. They are preventable. Process of drowning um, progresses through several stages. Uh, so I'm gonna highlight this for you. So you got panic. You become fatigued, injured, cold, entangled in seaweed, moss, kelp, whatever it might be. They experience a loss of orientation, and or you become ill. Feel of panic produces an insufficient breathing pattern. So anybody who's ever swam when you were a kid, I'll say, it can happen to adults too, obviously, is one, yes, you can get tangled on things, but the orientation, I almost drowned as a kid, so I get this one completely. I kind of got thrown into a pond by my cousins, but um, you go down, and if you turn or spin or something, you don't know what's up or down. You can't see. You're just thrashing around. That panic sets in. Um, what happens when we panic is we either take a deep breath or we do come up, but we can't catch our breath because we are in a full blown just panic phase. So our breathing pattern is all screwed up. Signs and symptoms of a submersion injury is coughing, vomiting, difficulty breathing, respiratory arrest, cardiac arrest, broken bones or spinal injuries, which we'll talk about, or hypothermia when wet or low temperatures and we get in water, right? Um, so that's kind of a really good order. I just want to point that out. So we start with gagging and coughing if we swallow a bunch of water. and then we try to vomit. We can't breathe, which if we can't breathe, what happens? We go into cardiac arrest, which leads to, or we go into respiratory arrest, sorry, which is very quickly followed by cardiac arrest, um, and that's drowning. Broken bones and spinal injuries. Um, I'm going to tell you, read your chapter. It goes more into detail, but anytime that there is a spinal or neck injury suspected, we do need to try to get them on a backboard. So we might have to move them. We might have to roll them in the water. We can still hold C-spine in water. We can still put them on a backboard. We want to try to put them on a backboard before we pull them out of that water, because what's the whole idea there is keep that spine in line, right? And stable. So if we can get them on a backboard in that water before we pull them out of that pool or lake or whatever, that's what we need to do. Assess the scene safe. So if patient's still in the water, do not exceed the limit of your training in a rescue attempt. There are people trained to go in water and rescue people. You and I are not. Um, Keep yourself safe and attempt the rescue only if you can do so safely. So what they recommend is that you use the reach, throw, row, and go sequence. So what that is we're going to try to reach them, even if that's with a tree branch, a pool net, whatever. We try to reach them. If we can't, then we can throw a flotation device or whatever we have available, something for them to grab onto. If that doesn't work, we can always row, which means we get in a boat and we go out, or the go sequence, which we're not trained to do, and that's where we go out at them, swimming out to get them. Call for that additional help. Definitely, it's going to be needed if they're out there very far or that water's deep. Um, if there's evidence of trauma, you need to move that patient to protect the spine. And we talked about. Um, I was going to throw one more thing in there, and I, for some reason, can't remember what it was. Oh, the reason we don't go, the reason we're not trained for this, what happens if someone's drowning? They are in a full panic. They are going to grab and pull up on anything they can get their hands on. So, with that being said, I'm a terrible swimmer. If I go out to rescue someone and they grab me and they're thrashing and they're trying to pull up so they can catch their breath, they're pushing me down. Um, and now we've got two drowning victims out there that someone else is going to have to try to come out for. Um, so if you're not trained to swim out and grab someone, if you're not trained to do that, we don't do it. And that's probably one of the worst feelings in the world is knowing that you're here to help people and you can't do it because it's actually going to cost you your life. Um, anyway, I want to throw that in. So we want to perform that primary assessment, perform a primary assessment, um, correct any airway, breathing, or circulation problems. Once again, is it open or do I need to open it? Are they breathing? Are they breathing adequately? And at what rate? And circulation, what's our pulse? What's our pulse rate and our quality? What's our skin look like? Cap refill. Begin CPR if it's indicated. If a patient is breathing adequately, administer high flow oxygen. Let's go ahead and flood them with those. We want to dry that patient off, cover that patient with towels or blankets. So we're treating for shock right there. We're giving them oxygen, we're covering them up. We want to get them laid down. As soon as possible, perform a secondary assessment to check for other injuries. Excuse me. Begin CPR on a drowning victim as long as the patient does not exhibit like definite signs of death. That's going to be the bloating. That's going to be the decompensation. That their rigor mortis has already set in. When a person's submerged in cold water, uh, I can't say this word to save my life, but mammalian diving reflex may be activated. So this reflex slows the heart rate and metabolic rate and decreases the body's demand for oxygen. There have been instances where survival of a patient submerged for over 30 minutes due to this reflex. It shuts everything down. It slows it down to its bare minimum. And people can actually be saved. When you encounter a person who has been submerged in cold water, start CPR and continue until that person has been delivered to a medical facility. Oh, excuse me. Hmm. Um, or that's if that medical facility is within, that 30, 40 minute. If you're super rural area and you're out there an hour, I'd be calling my medical director. Um, that's why they're there. So, lightning injuries. Electrical injuries result from a lightning strike and cause cardiac irregularities or cardiac arrest. Treat patients by supporting the ABCs. Give them high flow oxygen. We can defibrillate if we need to. CPR might be necessary. Um, and let's get them transported. Um, so these lightning injuries can and will cause electrical burns. Type of burn is mainly internally. Extent of the burn damage will not be visible right away after the injury occurs. With that being said, you can have, just like a gunshot, you can actually have an entry and exit with lightning strike, with power line contact. Um, there has been, I actually know someone who has been electrocuted and went through their body and actually blew their legs out. Um, that electricity needs to go somewhere. It goes through you. You're a perfect conductor, and it needs to get out. So be observant. Look for those entry exit burns. Yes, majority of it will be the burn on the inside that we can't see. Um, ABCs is crucial on this. And more than likely, we're going to be doing CPR, but we might also be working a trauma that has some sort of external bleeding injury, sometimes classified as environmental. Oh, sorry, bites and stings, sometimes classified as environmental injuries or discussed under topics of poisoning, which we've already done. Um, in this text, bites and stings are discussed in chapter 11, poisoning and substance abuse. Okay, that's all that's said about that. If you remember, real quick rundown, things you really want to watch for. We get stung or bite. We can clean that area with warm soapy water. We can take I think this book says to use like gauze and wipe away and try to get stingers out. I was taught to use like a credit card or bank card or something hard and stiff, and we can scrape across there and it will pull that. Never use tweezers or anything like that. Um, you're going to get that red mark, maybe some swelling. Let's go ahead and circle that with our Sharpie or our pen and just note what time it was. So when we get to the emergency room, if it has grown, we can see how much it's grown. We really, really got to watch for anaphylactic shock. So we want to ABCs, once again, crucial that we continuously monitor. Um, all vitals, I can't stress that enough. Our vitals should be taken every 2 or 3 minutes on these people, just so we can see any changes taking place. Um, yeah, and just continuous assessment. So the summary, we kind of talked heat cramps, heat exhaustion, heat stroke, what parts of the body are most susceptible to cold, hypothermia, what it is. There's hypothermia and there's hyperthermia. So remember, hypo is low, hyper is high. Um, they're not considered dead until they are warm and dead. Drowning can occur in numerous places. Um, they're preventable, so don't be afraid to educate people. Lightning injuries, um, they can cause dysrhythmias, they can cause cardiac arrest. Remember, they could have an entry and exit wound, and they're going to have internal burning damage. So heat stroke occurs when outside temperature exceeds 90, the body's heat eliminating mechanisms are overwhelmed. A person becomes dehydrated from excess perspiration, or the humidity exceeds 80. So we hit heat stroke, we quit sweating because our mechanisms are overwhelmed. We're shorting out, right? So I'm going to say B. There you go. You're called to the scene of a patient with deep frostbite. Which of the following actions would be appropriate for you to take? Provide pain medication, rub the affected area to warm it, arrange prompt transport, apply heat directly to the damaged tissue. Well, if they're that cold, medication's probably not going to do a lot because we're not metabolizing, so medication's not going to work. We don't rub. Remember what mom did when he was a kid is a no-no. Um, arrange prompt transport, apply heat. I did that because I wanted to make sure I was right before I said the wrong answer. So, we don't apply like direct high heat to damaged tissue. Um, we can put them in the truck, we can have the heater going, we can warm them up, and we want to get them to the hospital. When you encounter a person who has been submerged in cold water and is unresponsive, you should do nothing the patient's already did. Transport him or her to the hospital because only physicians will be able to treat the patient. Warm the patient before taking any other action. Start CPR. So let's just read that question. When you encounter a person who has been submerged in cold water and is unresponsive, you should. Well, I know there's a couple that definitely are not the right answer. Okay, that's what I thought. I wish they would have added more than just unresponsive. Most of the time, though, if we're submerged in cold water, you're not going to find a pulse, right? And breathing could be very minimal, if at all. So they're not dead until they're cold and dead. We don't transport, or we transport, but we treat them. We're not taxi drivers, so we can treat them before they get to a physician. Um, Warming that patient before taking any other action, we can warm them and be working on them at the same time. So CPR. Guys, thanks. I told you that one's going to be pretty quick. If you have any questions, reach out to me, and I will see you on the next one.